Hello and welcome back to the channel. Today I want to discuss how to use system thinking for general practice sustainability. GP practices across the UK are facing unprecedented challenge, which is that demand is rising while capacity remains constrained. Waiting times have lengthened, staff feel burnt out, and both patients and practitioners are currently suffering. Yet, some practices are navigating these pressures more efficiently than others. Have you wondered what their secret is? The answer lies not in working harder, but in thinking differently, specifically in adopting a system thinking approach to demand and capacity management. In this video, we want to explore practical framework for understanding your practice as an interconnected system where small strategic changes can create significant ripple effects in your system. Whether you're a GP partner managing financial sustainability, a practice manager optimizing workflows, or a clinician who is seeking to improve patient care, systems thinking offers you a roadmap through all of this complexity. So in the first part, we will explore how to understand primary care as a dynamic system. In the second part, we will talk about system thinking framework. And in the third part, I will introduce the concepts of data collection and data-driven practice management. In the fourth section, we will explore quality improvement methodologies and how to carry them out. And in the fifth section, we will use an example of understanding system dynamics during winter pressures as a way to bring all these system thinking frameworks into a practical example. And finally, I would share an overview bringing in concepts about policy, technology, particularly AI, and the future, and how I feel these concepts might be useful for you to navigate in this complex waters. So we've got a lot to go through, so let's get right into it. Part 1. How to understand primary care as a dynamic system. Your primary care is a business. While the heart of general practice is patient care, the reality is that GP practices operate as businesses, and GP partners hold contracts with the NHS England, who commissions these services through integrated care boards. You as the GP partner will manage the budgets, you can negotiate contracts, handle staffing, and make investment decisions based on the resources you get. So understanding the business mechanism of practice is essential to fulfilling your clinical mission. Primary care in the UK is the first point of contact for most patients seeking medical attention. It therefore plays a vital role in managing chronic conditions, preventive care, and acute illness management as well. So at its simplest form, your practice faces a mathematical problem. Patient demand must align with available capacity, and where these fall out of balance, the consequences will cascade. Your demand exceeds capacity. That means that your wait times will increase, your urgent cases can worsen and not be met, patient satisfaction will drop, and complaints will rise, and staff experiences moral distress. On the flip side, where capacity exceeds demand, your resources can be deemed to be underutilized, the financial sustainability might weaken, and practices may struggle to justify staffing levels. The art of practice management lies in maintaining this balance dynamically across different services, times of the day, and seasons, while the science provides you the tools to measure, predict, and optimize your service. But here's an uncomfortable truth that exists at the moment. Much of what GP practices function effectively exists as tacit knowledge in the minds of experienced GP partners and managers. As these GPs retire, this wisdom risks disappearing. And younger GPs, often burnt out and disillusioned, are increasingly reluctant to take up partnership roles. But my thinking is that system thinking offers a solution by making implicit knowledge explicit through frameworks, data, and processes. Practices can capture institutional wisdom and make it transferable. I believe that by teaching systems thinking, you will be able to augment intuition with the structure that you already have in place. So part 2, what is this system thinking framework? So the best way to approach primary care landscape is to think in systems. So every system, including your practice, consists of 3 fundamental elements: input, process, and output. What is an input? Inputs are what enters your system. So patient requests, phone calls, e-consult submissions, prescription requests, incoming referral letters, test results, and administrative queries. So your inputs feed the system and enable it to function. And there are also flows that enter the system. They are the rate at which new things arrive or are added to the stocks that you already have. For example, your rate of workforce retention, people coming in and out of your business. How about processes? So processes are how you handle these inputs, your triage protocols, your appointment scheduling logic, your consultation workflows, templates, prescription approval procedures, and administrative system. These processes usually will require a standard operating procedure, something documented step-by-step instructions that ensure consistency and quality. Outputs are the results: completed appointments, issued prescriptions, filed reports, satisfied patients, and sustainable workload for staff. Bear in mind that the quality of your output depends entirely on how well your processes transform the inputs into your desired outcomes. Let's do a little bit more about SOPs, because without SOPs, your practice relies on individual memory and improvisation. This creates vulnerability when staff are absent or new people join, and it can lead to a breakdown of consistency in the administrative, clinical, or operational workflows of your practice. So consider two essential examples. Appointment scheduling SOPs. How do you triage appointments? What criteria determine urgency? Who can book emergency slots? What's the escalation pathway when capacity is reached? How do you balance same-day demand with routine appointments? All this should be captured in a workflow process in your practice. How about medication refill SOP? How are repeat prescriptions request log? Do you know what safety checks are needed? Who authorizes non-routine requests? And how quickly must this be processed? What happens when medications aren't available? These are the type of questions that can help you decide which SOPs need designing and logging in your system, available for the staff to use. So taking a step back and looking at the system holistically, an integrated practice has at its center the electronic health record, which in any of the systems you operate in might be system one, EMIS, or another system. It sits at the center of a web of interconnected subsystems like your Windows Drive folders, your Agilo TeamNet for managing staff HR issues, and other third-party softwares. So optimizing awareness about these subsystems and how they interact with each other will enhance the system thinking apparatus of your team. For example, your clinical system would include systems around triage consultations, prescribing referrals, test ordering, and results management. Your admin system can encompass your appointment booking, patient communication, record keeping, documentation management. Your human resources system should have information about staff scheduling, training, performance management, well-being support. All these should have a way of easy accessibility and interconnectedness that every staff should be able to access. The practices that thrive are those that have consciously designed how these systems or subsystems interact. The practices that struggle are often the ones that have disconnected systems, creating inefficiency, duplication, and gaps. So your task isn't to create these systems from scratch, okay? Most of them already exist in some form. Your task is to identify which systems are dormant or suboptimized. You should reactivate them, connect them, and refine them, and make it available for everybody to use. The famous quote that I love so much when thinking about system is, "If you can't measure it, you can't improve it," by Peter Drucker. Which leads me on to think about the second component of system thinking, which is data-driven practice management. So far, we've talked about how a system is designed, so your input, process, and output. And I've introduced that concept for you to think about. I've also introduced the type of subsystems that might exist. Now let's think about how to bring out the voice of your system. And data management is what helps you to achieve that. Without data, practice management becomes a guessing game. You sense that waiting times are too long. You feel that staff are overwhelmed. You believe that certain times are busier, but feelings and beliefs don't reveal the root causes or measure improvement. So data collection is integral to system thinking, and we can't do without it. So because data transforms subjective impressions into objective insights. It reveals patterns invisible to individual experience, quantifies problems, and tracks whether the interventions are working. So I want to use an example to help drive this home. So what are the essential data points for demand and capacity analysis? The new JMS contract requires GP surgeries to allow patients to send in health and administrative queries online throughout working hours starting from October 2025. This means that practices will need to keep their online consultation tools open for the duration of core hours 8 a.m. to 6:30 p.m. for non-urgent requests, including appointments, medication queries, and administrative requests. So this aims to free up the phone lines and enable better triage of patients based on their medical needs. In order to understand your practice dynamics, you need to systematically collect your demand metrics. For example, total appointment requests by type, routine, urgent, emergency. You can collect phone call volume duration, online booking or e-consult submissions, and prescription requests or administrative queries. This gives you an insight into the demand side of the service you're providing. On the capacity metrics, you can collect available GP hours and consultation slots, staff availability, including absences, actual appointments delivered, and then administrative staff capacity. On the performance side, important data analysis to bring to bear will be time from request to appointment, on-field requests where demand had exceeded capacity, patient satisfaction scores, staff satisfaction and well-being indicators. Another tool in systems thinking is what we call benchmarking. Benchmarking is a useful way of deciding what good looks like. NHS contracts do not explicitly define performance thresholds for most demand and capacity indicators in primary care. There is no contractual mandate specifying maximum acceptable waiting times for example, routine appointments, or exact telephone response time targets, or specific capacity utilization rate. This absence of explicit thresholds creates both a challenge but also an opportunity. Without clear targets, practices can struggle to know whether their performance is adequate or whether they are falling behind. Conversely, practices have the flexibility to define meaningful benchmarks that reflect their unique context based on their patient demographics, geography, staff composition, and local healthcare ecosystem. So while NHS contracts lack explicit numerical thresholds, professional guidance provides useful reference points, and this is the point of benchmarking. So you can look to the BMA, who recommends a maximum of 25 patient contacts per GP per day for safety and sustainability, and also recommend, let's say, 15-minute appointment slots to improve consultation quality and reduce repeat visits. Another place to look for benchmarks would be the NHS England guidance, which emphasizes high quality telephony systems to manage access effectively. They also recommend data-driven capacity planning to identify and address demand capacity mismatch, and building robust data collection and analysis capacities. And more recently, the drive towards total triage has created an infrastructure that facilitates better data collection analysis of demand and capacity patterns. So most practices can now have access to several digital tools like Accurex, System Connect, and Clinic. You can also develop your own in-house collection templates on your respective electronic health record. For example, a decision support template like the one I'm showing here facilitates how clinicians may choose to process a triage, adding relevant codes to the System 1 tab journal for the purpose of generating different types of reports, including appointment utilization. Can also afford you an opportunity to benchmark how different GPs are analyzing triage requests, which is particularly helpful when you are trying to improve your service. Another key framework or tool to bring into system thinking is establishing your practice's specific key performance indicators. KPIs are very important as a practice when doing systems thinking and analysis of your practice. Given this landscape, each practice must take ownership of establishing its own KPIs, and this should be context specific, that is reflecting your patient's population needs. A practice with many elderly patients will have a different capacity need than one serving primarily working age adults. Your KPIs should be resource aligned, including your actual staff availability, physical infrastructure, and the funding that you have. The KPI should be evidence-based, should be grounded in your own historical data if you've been collecting them, showing what's achievable and what's indicating stress for you. And you should also be able to review them regularly, adjusting it in response to your changing circumstances, contract modifications and the lessons you've learned over the years, it should also be collaboratively developed, created in consultation with your local integrated care board and other relevant health authorities that you work with. Practice with specific KPIs can set meaningful, achievable targets that drive genuine improvement rather than arbitrary benchmarks that don't reflect your reality. KPIs should track the efficiency and effectiveness of your practice operations while remaining honest about the constraints that you face. A useful way of presenting your KPI will be to present whatever you've chosen in a visually appealing way. What are the key characteristics of a well-designed dashboard? It should be real-time. On the subject of demand and capacity, you should have real-time view of your demand and capacity gaps. Trend lines can be visible to show which metrics are improving or deteriorating. You could add time frames to it by day, time, season. With regards to capacity, and present your data visually that shows the staff workload distribution or patient access metrics or the financial performance indicators where it's appropriate. The goal isn't to create beautiful graphs, it's to stimulate productive conversations. When the practice team sees objective data, discussions can shift from blame. For example, instead of saying we're overwhelmed because we're short-staffed, you can start hearing statements that suggest problem solving, like saying we have capacity gap on Tuesday morning. What options do we have to fix it? That's a more proactive way, and KPIs can help you start to bring in that type of conversation in your strategy meetings. Another system thinking language or tool that you would find useful is feedback loops. So far we've discussed your practice as a collection of inputs, processes, and outputs, essentially a static picture. But practices don't operate in steel frames. They are dynamic systems that respond and adapt over time. This is where system thinking becomes truly powerful. It helps us to understand not just what's happening, but how different parts of your practice influence each other in an ongoing cycle. So when you change one thing, ripple effects can spread throughout the system. Sometimes these ripples amplify the change, making things better or worse faster than expected, and sometimes they can dampen it, pushing backward towards stability. Understanding these dynamics require grasping one crucial concept, which is the feedback loops. So when an action produces results that influence the original action, it creates a circular chain of cause and effect. And these loops are constantly operating in your practice, often invisible, determining whether problems resolve themselves or spiral out of control. Think of your practice like a thermostat system, okay? When the temperature drops, the heating turns on, and when it gets warm enough, the heating turns off. The system self-regulates through feedback. Your practice works similarly, but with far more complex and interconnected loops. There are three main types of feedback loops shaping your practice. First one is a reinforcing loop. It amplifies change. These loops accelerate trends in whichever direction they are moving, creating either a virtuous circle where good things get better or vicious cycle where problems are getting worse. Example of a virtuous circle is better staff morale leads to higher quality patient interactions, which then leads to more patient satisfaction, which then leads to fewer complaints and less administrative stress, better morale, and the cycle continues. Each turn of the cycle strengthens the trend. Success will breed more success. An example of a vicious cycle is something like staff shortage, which can lead to increased workload for remaining staff, which can lead to burnout and sick leave, which lead to further staff shortage, and the cycle worsens. Each turn makes the problem worse. This is why workforce issues can deteriorate so rapidly. The feedback loop accelerates the decline. The second type of loop to discuss will be the balancing loop, what we call self-stabilizing loops. So these loops push the system back towards equilibrium, acting as natural brakes that prevent runaway change. Okay, an example is long waiting lists, which can lead to patient complaints increasing, which then lead to practice leadership responding by engaging local clinicians, which then lead to waiting times reducing, complaints decreasing, and system stabilizing. So balancing loops are your practice's shock absorbers. They help you weather temporary surges without permanent damage. The third type of loop to reflect on is external regulatory loops. These are forces largely outside your control that still influence how your system behaves. For example, NHS policy changes when new contracts come in or funding adjustments are transmitted to you, public health campaigns, changing patients' awareness and expectations, seasonal patterns, predictable winter demand and summer staffing, local healthcare dynamics like the hospital capacity affecting primary care demand. Understanding which type of loop you're dealing with is critical for effective intervention. Try to stop a reinforcing loop with a weak or token balancing intervention, and you'll be frustrated when it fails. So reinforcing loops have momentum. Breaking them requires interventions powerful enough to overcome their amplifying force. Similarly, if you ignore a vicious cycle, it will overcome your practice. Let's explore some examples of putting this into practice. The staff burnout vicious cycle in a reinforcing loop. Staff shortage lead to increased workload, which leads to burnout, and then sick leave, and then further staff shortage, accelerating the decline of the practice. A weak balancing intervention that fails can look like where leadership sends a well-being email encouraging staff to practice self-care. The result is that the reinforcing loop continues, gestures don't address the root cause. On the flip side, a strong balancing intervention that works would look something like hiring a locum GP to immediately reduce workload, redistribute admin tasks to free up clinical time, implement protected time that's actually enforced, and the result is that you break the cycle by genuinely reducing the pressures driving the burnout. Let's look at another example using the patient dissatisfaction spiral in a reinforcing loop. So the loop says that long wait times will lead to angry patients, more complaints, staff spend time handling complaints, less capacity, longer wait, and a worsening spiral. A weak balancing intervention that fails will look like asking patients to be kind to staff, or you send apology letters. The result, it doesn't address the capacity issues and the spiral continues. A strong balancing intervention that works will be implement comprehensive digital triage to better match demand to capacity, add evening or weekend clinics temporarily, bring in additional administrative staff to handle complaints efficiently, and the results will be that actually reduces wait times and breaks the cycle. So success really breeds success. In a loop where there is good staff morale and better patient care and positive feedback and staff is feeling valued, even more better morale is experienced, which is a virtuous cycle. An inappropriate balancing intervention, if leadership sees morale is high and thinks, oh, we can now push them harder or cut resources by saying that they're managing fine, the result will be sabotaging your own success. Let's see how these feedback loops play out in real time during winter pressures when your practice is facing its annual stress test. So far, we've discussed inputs, processes, and outputs, the flows through your system. But to fully understand system dynamics, we need to add another element, stocks, which is the accumulated resources that exist within your system at any given time. While inputs and outputs are about flow, measured as rates, stocks are about accumulation, measured as quantities. Think of stocks as your practice's accumulated resources, like your human capital, which is like a GP workforce, nursing team, administrative team, and their collective skills and capacity. Another stock is your physical capital, which is like consulting rooms, equipment, technology. Another stock would be organizational capital, which are your relationships, reputation, institutional knowledge. Financial capital, which is your reserves, your funding streams and investment capacity. And patient trust can also be considered a stock, whereby the goodwill and the confidence the community has in your practice. These stocks fluctuate. Staff leave or get sick, equipment fails, funding changes, and patient trust can be eroded or strengthened based on your performance. Of all the inputs, the GP and healthcare workforce is the most limited and critical. And the reason is that any short supply you have, let's say for example a GP retiring early due to burnout or recruitment isn't keeping at pace, it can really spiral out of control. When GP numbers fall below threshold, the entire system disintegrates, access deteriorates, emergency department attendance rises, patient satisfaction plummets, and remaining staff experiences increased pressure, creating a vicious cycle. Practices are at risk of closure when recruitment is severe, and this can really drive things down a spiraling vicious cycle. What is the driving force behind a practice's response during winter pressure? It could be leadership decision making, which can have a positive or negative impact, poor data forecasting, your staff well-being initiatives that you have on ground already, and external support that you can receive. Each of these can have positive or negative impact. Looking at demand and capacity and using system thinking, winter pressures usually produce predictable interactions, and the demand drives intensity. Seasonal illness, vulnerable patients, hospital discharge delays, public anxiety about accessing secondary care, which restrict capacity that you have because staff absences as well can rise due to illness, exhaustion, or leave. Remaining staff face higher workload intensity. Technology systems may struggle under peak loads. External support might also be difficult because local availability and urgent care services are equally strained. And the system can then respond, which can determine the outcome that you see. If your balancing mechanisms are strong, your triage is efficient, you have capacity to provide extended hours or local GP temporary to expand your capacity, or you have opportunities to provide remote consultations, or you have good signposting connections in the community. These are strong balancing mechanisms that might self-correct your system. But if negative reinforcing loops are dominating, crisis spiral. Your overworked staff become sick or leave, longer wait time cause patients to worsen, increasing your urgency. Staff morale can collapse, and the practice enters a spiral. The key thing using systemic thinking to evaluate how you've responded through a winter period is identifying leverage points. Some of the actions have minimal impact while others have transformational change, and high leverage interventions that you can think about when reviewing a winter pressure activity is how well you protected staff well-being, optimizing triage, a very effective way of matching the patients to the right care at multiple levels, implementing a very robust SOP to reduce variability of practice between clinicians, which can free cognitive resources as well to reduce burnout, and introduce AI support for automated admin activities and provide organizational resilience. So systems that are flex under pressure can recover faster. The key insight to take away when using system thinking to look at how you responded to a winter would be how well your workforce was resilient. Because if you protect your workforce, the practice can weather any storm. But if you neglect it, your entire system becomes very fragile. I want to go through one final tool which I think is relevant for system thinking, and it's very useful to bring the theory of systems thinking into practice to effect measurable change, and that is quality improvement in practice using the Plan, Do, Study, Act methodology. This methodology provides a disciplined framework for testing changes and learning what works. To use this framework, every quality improvement project needs a specific measurable aim. For demand and capacity, an effective aim might be to reduce the average time for routine appointments from 14 days to 7 days within 6 months, while maintaining same-day access for urgent cases without increasing staff overtime. So notice the specificity here. Looking at this aim, you would find answers to what will improve, by how much that would improve, by when, and with what constraints. You can find a link in the video of how to write a good aim statement for your QI project. The other aspect of using a quality improvement methodology is setting a family of measures, and this is used to track your progress. You need 3 types of measures. One will be your outcome measures, which answers the question, did the intervention achieve the desired result? And the second is process measures, which is the intervention being implemented as planned? And then balancing measures tries to answer the question, are there unintended negative consequences as a result of what we're doing? All 3 are essential, and focusing only on outcome measures can miss implementation failures or create new problems elsewhere in the system. In our example that we used about demand and capacity, PDSA cycle can then be applied on your measures. So in the plan phase, you collect baseline data on current demand and capacity constraints, identify peak pressure points and bottlenecks, select a specific intervention. During planning phase, you can predict what should happen if intervention works. In the do phase, you implement the change on a small scale. For example, you stagger the implementation time frame, use one location at a time, document exactly what happens in the do phase, track your progress using your family of measures, and gather qualitative feedback as well. In the study phase, you compare before and after data, analyze whether the intervention worked as expected, identify any unexpected consequences, either positive or negative, or understand why the results occurred and reflect on it. In the act phase, if successful, you scale the intervention across the practice. If unsuccessful, you either modify and test it again, or you abandon and try a different approach. If particularly successful, refine it and iterate it, and make sure to document for your organizational memory. This is a very useful way to carry along organizational progress and successes. Let's bring this all together, okay? While improving practice is essential, it's worth acknowledging the broader context here. Primary care faces structural changes that individual practices cannot solve on their own. Funding models that don't fully reflect the complexity of the cases we manage, workforce pipelines that aren't producing enough GPs, system interaction gaps between primary, secondary, and social care, policy volatility that makes long-term planning difficult. Effective advocacy for better policy requires practices to demonstrate what works and what doesn't, which brings us back to data and systems thinking. And these all plays a role in how we address some of the new things coming into the system. For example, AI revolution. Is it a threat or an opportunity for your practice? So artificial intelligence is entering healthcare rapidly and primary care will be transformed. So the question isn't whether AI will change your practice, but how you shape that change. And there are various ways that AI is already being used in the practice at the moment, particularly around AI medical scribes and administrative automations. But there are new things coming on the horizon. You need to be ready to apply these things straight away into your systems. Beyond clinical tools, AI can also enhance practice management right now, like using it for data analysis, using it for strategic thinking support, and using it to explore scenarios and test assumptions and develop improvement strategies. It can also be useful as a way of rapidly synthesizing guidance, document research to inform your decision. It will help you gain competitive advantage in efficiency, quality, and staff satisfaction. Those that resist this type of change would risk falling behind as patient expectations and NHS requirements evolve. In this video, we'll focus on systems, data, optimization. At the heart of why all of this is relevant is the invisible stock that powers everything purpose. Most people enter primary care because they want to help patients and serve the communities. This altruistic motivation is a resource that can be depleted or replenished. And when practice management focuses solely on efficiency and profitability, staff feel like cogs in a machine. When it balances operational excellence with meaningful patient care and staff well-being, people can thrive. And practical ways to preserve purpose in your practice is by regularly sharing positive patient outcomes and stories with the team, involving your staff in improvement projects because they have the insights and value being heard. Celebrate small wins, not just the financial metrics. Protect time for the kinds of patient interactions that remind clinicians why they choose this profession, and make staff well-being a key performance indicator that's equally important to patient access. Take your own journey of system thinking with all this information that I've shared with you today. Primary care is complex, it's a pressured system, and sometimes can be overwhelming. But complexity isn't chaos, it's an opportunity for you to find a pattern. And understanding these patterns through system thinking will empower you to work with the forces shaping your practice rather than against you. Always remember that your practice is a system, not a collection of disconnected parts. Use data effectively to identify patterns. Read your feedback loops to know what amplifies successes and failures and learn what they are. Your workforce is your most critical and fragile resource. Protect it. Technology is a tool, not a solution. Use it thoughtfully, and remember that purpose matters as much as efficiency. System thinking wouldn't solve all your problems, but it will give you a map through complexity, at least a language to discuss challenges clearly, and a framework to turn insights into action. Your patients deserve better access, your staff deserves sustainable workload, your practice deserves financial sustainability. System thinking can help you achieve all three. And I hope that this video provides an overview of how to apply systems thinking in primary care to enhance service delivery and sustainability of your practice. Best wishes in your career.